Thank you for the opportunity to speak about pediatric alopecia areata and the role of Atopy. My name is Leslie Costello. What a fascinating subject in light of the recent clinical trial by Dr. Gutman's group showing patients improving with Dupixent, a medicine FDA approved for atopic dermatitis. And so fascinating in light of 40 plus years of noting a connection between atopic dermatitis, allergic rhinitis, and other atopy, and alopecia areata. Does it affect severity? Does having pediatric atopic dermatitis increase your risk for alopecia areata? And if you develop alopecia areata, does it impact your severity? Does it impact your ability to respond to therapy? And when we think about the connection between alopecia areata and atopic dermatitis or atopy, it comes, within a background of knowing that alopecia areata has generally been considered the cell-mediated, tissue-specific autoimmune hair disease. That most of the signals that have been identified, particularly with the work on the JAK kinase inhibitors, show that this is a type 1 inflammatory disease with key cytokine being interferon gamma. Atopic dermatitis, on the other hand, is generally considered to be a Th2 response. So, this conflicts with the idea that alopecia areata is really only interferon gamma driven, especially with data that supports patients with alopecia areata having a higher chance of allergic background or atopy. There certainly are subsets of patients who have an atopic signature, and I hope I'll be able to talk a little bit about these subsets of patients. When I think about the subset of patients where atopy seems to contribute to the systemic activation of autoimmune mechanisms in their alopecia areata, I think about patients like this. So this young boy has a history of severe atopic dermatitis with superinfection, and he later went on to develop alopecia universalis. And despite his eczema getting better with treatment, he did not have resolution of his alopecia universalis. So today I'm going to talk about 4 general areas. What the evidence is for comorbid atopic disease with some emphasis on children. What are the genetic relationships that show that connection between atopy and alopecia areata? Data on seasonal relapse, which may be related to seasonal rhinitis, and then therapeutic interventions in children and adults which support a connection between alopecia and atopy. So I've written a few reviews on the epidemiology of alopecia areata, and it's an area of interest. And yet every time I look, I find new data that surprises me and data that has been out there for a long period of time that kind of surprises me as well. I think, a statement that epidemiology supports a relationship between atopy and alopecia areata is true. When I was putting this talk together, I always go back to see, is there anything I missed on this subject? Is there any epidemiology which would be, exciting to include? And this is a paper that I found from 1967, which talks about alopecia areata and atopy from Catholic University. This paper quotes a paper that had been written just 2 years before by a Japanese researcher, Ikeda, who had published 4 types of alopecia areata, a common type, a pre-hypertensive type, a combined type, and an atopic type. And so I went back to that paper to see what did they say at that time in the 1960s about the atopic type. So even in the 60s, when we didn't have a good sense of the immunology of alopecia areata, there was a sense from clinical observation that there were a subset of patients that atopy played a big role. And in these patients, atopy led to longer duration of disease and perhaps severity of disease as well. If we jump ahead, 40 years, Carolyn Go, looked at 500 patients with alopecia areata and found a higher incidence in those who had atopic disease. And so in this case, 46% of patients had atopic disease. Having atopic disease, which included atopic dermatitis, allergic rhinitis, and asthma, led to younger age of onset. So of course these studies are including children and adults, but the mean age was 20 years versus in non-atopics 23, almost 24 years. It also led to a higher odds ratio of more severe disease. So you can see that in this table that having atopic dermatitis, you had a higher odds ratio of more severe ATAU, as well as just a higher odds ratio overall of alopecia areata. A similar correlation between atopy increasing your risk for alopecia areata and atopy increasing your risk of severity of alopecia areata was found by Madeline Duvik's group using the NAAF registry. And you can see that in this table that having any form of atopy before diagnosis of AA increased your odds ratio to 1.27, and asthma increased your odds ratio to 1.39. And my task was to look, specifically at pediatric alopecia and that role of atopy. This is a little bit more difficult to find because most of the studies include adults and children. But this paper, published in the JAD in 2011, did show that there was an increase of atopic dermatitis found in childhood alopecia areata, and childhood alopecia areata was defined as kids younger than 10 years of age. Up until this year, when Dr. Gutman's group published a paper with 50,000 patients, this paper by Qureshi's group of 2,000 individuals with AA seen between 2000 and 2011 was one of the largest studies which showed the association between atopy and alopecia areata. In their study, they showed about 38% of patients had atopy in addition to their alopecia areata, making it the most prevalent comorbid condition. And this is in keeping with 6 additional cross-sectional studies which have reported that the prevalence of AA and a personal history of atopy ranged from about 22% to 38%. So this is that large population-based study that was just reported in February of 2020, looking at a population in Israel, and showed that alopecia areata was associated with atopic diathesis or atopic disease. In this study, you can see in this table that if you had a history of asthma, you had a younger age of onset of alopecia areata. And if you had a history of atopic dermatitis, you had an even younger age of onset of alopecia areata. So, someone without either age 34, someone with asthma age 33, someone with atopic dermatitis age 26. And having asthma, allergic rhinitis, atopic dermatitis, or allergic conjunctivitis increase your odds ratio of alopecia areata. To summarize the epidemiology of atopy, having atopy increases your risk for developing alopecia areata. Atopy leads to younger age of onset of alopecia areata. Atopy is associated with more severe disease. Now that we've established a connection between alopecia areata and atopic disease, does the atopic disease affect flares? I think the best evidence for this is the seasonality that many patients report with their alopecia areata, and that seasonality often correlates with their allergic seasons. I became interested in this because of what I was being told by patients and their families. They were reporting to me that for many patients, their flares of alopecia areata were seasonal. They could predict the time of year that they were going to have a flare, and often this correlated with their allergic rhinitis or their atopic dermatitis flares. So we did a retrospective study in 2018 looking at patients with known history of atopy and patients without atopic disease, and asked when did these patients develop most of their flares of alopecia areata. What we found was interesting, that during late spring and summer there were fewer flares, as many of you probably know from seeing patients, and that peak flare times were in March and November. The peaks in March and November were more significant for patients with atopic disease. This fits really, beautifully with work that has been done with seasonal variation and monthly patterns of flares of atopic dermatitis in children. This is a Korean study which looked at skin symptoms in children with atopic dermatitis. And you can see, you can almost superimpose both of these, graphs and bar charts onto each other. So this suggests to me that there's something about that allergic flare, atopic flare that drives alopecia areata flares. And even though we kind of think of these allergic or atopic flares of Th2, that Th2 response is affecting alopecia areata flare severity. So in all this recent work done with genetics, has there been shown a genetic relationship between alopecia areata and atopy? In 2007, Betts in the Journal of Investigative Dermatology showed that filaggrin mutations, which we know are often associated with atopic dermatitis, were significantly associated with presence of atopic dermatitis among alopecia areata patients, and the presence of these filaggrin mutations had an impact on the clinical course. So in the 22 patients who were carriers of filaggrin mutation, 19 of them showed severe disease. So your odds ratio of severe disease when you carried this filaggrin mutation was 5.47, significant. So do the genome-wide association studies support a connection between atopy and alopecia areata? Although the big news that came out of the initial genome-wide association studies from Dr. Cristiano's group showed the importance of JAK signaling, and also the importance of keratins and genes specific to the hair. Follow-up studies of that first genome-wide association study did show that there were certain susceptibility loci, including IL-13. IL-13 is a really interesting finding in this study, because it's often considered a cytokine related to atopy. IL-13 is a pro-fibrotic cytokine. It is important in Th2 response. It is usually associated with atopic disease and asthma. Significantly, an IL-13 SNP was found in alopecia areata associated with atopic dermatitis, and the same polymorphism had been shown to regulate IgE levels in asthmatic patients. This brings us to start to see alopecia areata as an immune disease that has contributions from both Th1 and Th2 mediators, and in a subset of patients shows perhaps the importance of key regulators of IgE levels which we will see as important when we start to look at therapeutics for patients with alopecia areata and atopic dermatitis. So now that we see IL-13 involved, and we know that IL-13 is a key regulator of IgE levels, we start to think about, is this subset of patients really at higher risk because of their atopy, or at higher risk because of their eosinophilia or their IgE levels, or something else that is concomitant with their atopy. Ratnaparkey in 2016 looked at 205 patients with alopecia areata and concomitant atopy and found that about 18% of the patients were classified as having high eosinophils. Eosinophils in these patients, or the subset of patients with high levels of eosinophils, had a significantly higher odds ratio of developing severe disease than patients who just had atopic dermatitis but low levels of eosinophils. There are only a few papers that kind of separate out eosinophilia or IgE levels from atopic dermatitis or atopic disease. So there's one in 2014 which looked at 50 patients with alopecia areata and compared them to 50 age-matched and sex-matched controls. They excluded patients with atopic disease, which included asthma, atopic dermatitis, allergic rhinitis, food allergies. And in the patients with alopecia areata, they found higher levels of total IgE. So these are not the type of levels that are seen in STAT3 mutations or in primary immunodeficiency patients, but they are IgE levels in the 100 to 200 range, which is often what you see in individuals with atopic dermatitis. The second paper was really looking at a specific HLA subtype. But in this paper, they looked at IL-4 and total IgE levels in non-atopic alopecia areata patients with this particular HLA DRB1 subtype. They found that total serum IgE levels and IL-4 levels were elevated more in alopecia universalis than in other forms. They also correlated the onset of alopecia areata with the levels of IL-4 and IgE. Specifically, they noted that the longer the patient had disease, the higher the levels of IL-4 and IgE were present. And they suspected that these elevated IgE and IL-4 levels could be related to their HLA profile. So we're starting to see this theme of, high IgE levels, high IL-13, plus or minus atopic background as a predictor of alopecia areata severity and a predictor of perhaps ability to regrow. This was a Korean paper that looked at patients with low, moderate, high, and very high levels of IgE and their ability to grow hair, and found that those patients with low IgE levels, which they defined as less than 100 international units per milliliter, had the highest rate of complete regrowth and low rates of aggravation or no hair regrowth. Those with the very high levels had the least chance of complete hair regrowth and had high levels of what they refer to as relapse or aggravation or no hair regrowth. Many of us, of course, were aware of the IL-13 signature from the GWAS studies in patients with alopecia areata, and of course we were all looking for new therapies for our patients and safer therapies for our patients. And so when Dupixent was approved for atopic dermatitis, and particularly for me, when it was approved in age 6 and over for atopic dermatitis, we all started to think about, could this be an option in those patients with an IL-13 signature, or at least an atopic signature, since we needed to treat their atopic dermatitis anyway. So of course, we know that dupilumab is a monoclonal antibody that binds to the interleukin-4 receptor. And through its blockade of this receptor, it modulates signaling of both IL-4 and IL-13. So with the thought that, gosh, we have a treatment for atopic dermatitis, which is a new type of treatment, perhaps a more effective treatment than some of the things that we have been using before, like methotrexate or topical steroids. Could we, in patients who had both atopic dermatitis that was moderate to severe and alopecia areata that was refractory to therapy, use dupilumab as a treatment for both? And so this was a report published in 2021 of 16 patients who were treated primarily for their atopic dermatitis, but also had alopecia areata. And we followed patients for 12 months on therapy and found that those patients with moderate to severe atopic dermatitis had good responses with improvements in their SALT scores when on dupilumab therapy. This is one of my patients who had refractory biasis pattern alopecia areata for 6+ years, had endured many injections at her parents' request, topical steroids, systemic steroids, and methotrexate, who was put on dupilumab, and within 6 months had full regrowth of the eophysis pattern alopecia areata, and at 12 months really had a recovery of her typical scalp hair, and 18 months of therapy continued to have regrowth with no relapse. And of course, this mirrors the paper that was reported just in August of 2021, the phase 2A trial of dupilumab for alopecia areata patients from Dr. Gutman and Dr. Kruger, where 40 patients were put on Dupixent and there were 20 controls. And after 40 weeks of Dupixent, patients with baseline IgE levels of greater than 200 had excellent rates of response. And baseline IgE levels actually predicted treatment responses with about 83% accuracy, suggesting that Dupixent is a better treatment for patients either with an atopic profile or elevated baseline levels of IgE. These are the clinical pictures from this clinical trial showing 4 subjects with improvement in their alopecia areata over 24 weeks. You can see multiple of the patients have more than 50% hair loss, and you can see on the right, top right, patient with significant eophysis pattern alopecia areata with great improvement. Patients with high IgE levels, which were greater than 200 international units per milliliter, had the highest rates of SALT 30, SALT 50, SALT 75, and SALT 90 at 24 weeks, and also had high levels of achieving SALT 30, 50, 75, and 90 at 48 weeks. I like this figure from the paper because it really differentiates the 2 subpopulations of patients, patients with in dark maroon with IgE levels of greater than 200, and patients in green with IgE levels less than 200. So you can see the different responses over time up to 72 weeks. in those on dupilumab with low IgE levels and those with high IgE levels. And you can clearly see that those with higher IgE levels have better SALT 30, SALT 50, and SALT 75 responses. There's still so much to learn about the connection between alopecia areata and atopic disease. We need to refocus our thought about the immunology of alopecia areata being both Th1 and Th2 mediated. We need to start thinking about the larger alopecia areata community as subsets of patients who might have different targets and different therapeutic options, particularly those that have atopic disease, elevated eosinophils, or elevated IgE levels. We need to understand why patients who have atopic disease develop alopecia areata at younger ages, and whether some of these targeted therapies could be disease modifying and perhaps prevent patients with severe atopic disease from developing alopecia areata. We need to understand the connection of the skin and the gut microbiome in really young children and how that has an interplay with the immune system and the age of onset of alopecia areata and perhaps the severity of alopecia areata. I think it's exciting to have potential new targeted therapies for some patients with alopecia areata, but there's so much more to learn. Thank you for your attention.